Welcome to this fourth edition of the Points of Care, the official podcast of the journal Diabetes, Obesity, and Cardiometabolic CARE. This is the American Diabetes Association's journal for clinicians, educators, and advanced practice professionals, launched earlier this year. I'm your co-host, Dr. Richard Beaser, and with me, of course, is my co-host, Dr. Jane Reusch. Jane?
Thanks, Rich. Looking forward to our conversation today.
Absolutely, Jane. There's certainly a lot to talk about. And as usual, we've invited authors of two of the key articles from the latest edition to talk about their work. We're also going to point out some important material in this edition on two things, the obesity standards of care, as well as a statement by the ADA on employment and diabetes, an issue that's been of concern for many of us for decades. And of course, we'll also highlight four other articles that we think will be of interest. So, Jane, let's begin with our interviews of the authors from the two key articles.
Well, it's with great pleasure that I introduce one of the authors of our first article, Dr. Katherine Tuttle. Dr. Tuttle is the Executive Director of Research at Providence Inland Northwest Health and a professor of medicine at the University of Washington School of Medicine, where she also serves as an academic clinical professor of nephrology and regional co-principal investigator of the Institute of Translational Health Sciences. The title of the article that we're going to discuss today is SGLT2 inhibitors for the primary prevention of CKD in type 2 diabetes, a systematic review and meta-analysis. So, Dr. Tuttle, tell us, what was the motivation behind this project and which gaps were you trying to address?
Well, as this audience probably knows, the world changed with the advent of the SGLT2 inhibitors for multiple reasons. And they first came to our attention, of course, as new glucose-lowering agents for people with type 2 diabetes. And then when the cardiovascular outcome trials were accomplished, we saw that in addition to their metabolic effects, that there were rather profound effects, particularly on heart failure. And in those cardiovascular outcome trials, certainly a signal for kidney protection as well. And then we went on to do our big kidney disease trials in people with type 2 diabetes and CKD. And then they quickly expanded to non-diabetes related CKD, and they became the biggest win yet for kidney disease, markedly reducing risk of true outcomes, kidney failure, and mortality outcomes by nearly 40%. So it really has, these drugs revolutionized the field. But we did the trials in people with established kidney disease or established heart failure. And we realized that these drugs were originally used for the treatment of diabetes, and that if these agents were so effective for treating the disease, if we walked back to earlier stages in people with type 2 diabetes, would there be a benefit on preventing CKD to begin with?
So, with that in mind, can you give us a brief overview of the key results?
Sure, I'd be happy to, Rich. So we did a systematic literature review to find studies of people with type 2 diabetes who were treated with SGLT2 inhibitors. And these were all placebo-controlled trials, and asked the question of whether or not there was evidence for prevention of kidney disease. And we had very strict criteria. They had to have normal kidney function, so 85% of the people had to have a GFR above 60 or a UACR below 30. And the reason I say that is even in the diabetes trials, there will be a mix of people who get in. So we can't completely eliminate all early CKD, but we tried very hard to be as inclusive as possible, but balancing it with the practicality of having enough data for the analyses. And what we learned was that these drugs are, at least based on systematic review criteria, do prevent kidney disease. And we looked at it in two ways: onset of albuminuria, more than 30 milligram per gram. And we also used a higher threshold to over 300 milligram per gram. So either micro or macro albuminuria. And then we also looked at estimated GFR outcomes, whether by a discrete change to dropping to less than 60 or slope. And really across the board, where we were able to find the studies and have adequate data, It met all the criteria, prevents onset of micro and macroalbuminuria, and preserves kidney function, whether we look at it by simply a drop in GFR below a threshold or slowing the rate of kidney function loss even within the normal range.
So this is really an exciting story and very important for primary care docs. So would you tell us where you think you are going to be going with your next steps in terms of taking this research to the bedside?
Well, I think this is following a pattern that we've seen perhaps, most abundantly in cardiology of primary prevention. So we certainly have the secondary prevention data. Now we have systematic review and meta-analyses of people who entered studies for other reasons, but strongly pointing to the evidence that in people with type 2 diabetes who are treated early with SGLT2 inhibition, it substantially reduces the risk of developing kidney disease, whether marked by loss of function or albuminuria. And I would point out, also I want to triangulate this with cardiovascular disease, is that albuminuria and GFR decline are also markers of adverse cardiovascular events. So we really can think about primary prevention maybe more holistically within the cardiovascular kidney metabolic framework. And so a trial for primary prevention, of course, would take a lot of fortitude and resources. But I do think that, we're also considering novel trial designs that perhaps could be less expensive, less laborious. But I guess what I would say is I think our field, and you're right, particularly this would really be the community of people who take care of patients with type 2 diabetes. So that's mostly primary care, but other types of clinicians too, to start thinking about using these agents early to save kidneys, hearts, and lives, as well as treat their diabetes.
Yes, and so I think you're speaking to the converted here, and yet I'm trying to imagine exactly how you would design your fantasy trial in order to allow this to be evidence-based and included in guidelines.
I think in the case of treating type 2 diabetes, so now we have to think about who's in the study and what problem we're trying to solve. I do think that in this case, most people would have to have a treatment for type 2 diabetes. So this would be more of an active comparison study. Is it better than the standard, whether that be metformin or something else that people are commonly using in practice? And of course, metabolic outcomes are important, but those have already been established. I think the real question would be, can we prevent prospectively onset of albuminuria and loss of GFR? I think it would be unrealistic to try to do a hard outcomes trial to follow them all the way to death or kidney failure, but we could do GFR and albuminuria outcomes trials. And those have become accepted surrogate outcomes, particularly in diabetes by regulatory agencies. So I do think it could be done, Jane, especially if we used those types of outcomes.
Thank you so much for bringing this paper to this journal and doing this work, because I do think that it sets us on the path for prevention rather than treatment of diabetes complications. And I think that's what gets all of the three of us up in the morning.
Absolutely.
Absolutely. Thank you, Catherine. I'm pleased to introduce one of the authors of the second article that we're featuring today, Dr. Alexander Turchin. Alex is Director of Informatics Research at the Division of Endocrinology at Brigham and Women's Hospital and Associate Professor of Medicine at Harvard Medical School. The title of his article is Trends in Diabetes Medications After Metformin in High versus Moderate Cardiovascular Risk Patients, the BESTMED Consortium 2014 to 2022. Alex, thank you for joining us today. We know that a great deal of attention is being paid to medication selection for people with type 2 diabetes. Can you briefly outline the objectives of your study and the specific gaps in our knowledge that you sought to address?
Of course. Thank you for having me today. So the reason we did this study is that treatment of diabetes has really been upended over the last decade. Now, if you go a few decades ago, all we had was sulfonylureas and insulin. And now we have dozens of medications. And these medications we now know they don't just lower blood glucose. They also have a range of other benefits, cardiovascular and other benefits for patients with diabetes. So unsurprisingly, we know anecdotally, we know systematically that treatment patterns are changing, but there are different populations of patients. There are populations of patients for whom these extra benefits besides blood sugar lowering are established, and then there are the ones that are not. And so we wanted to know, are there actually differences in how prescribing is changed between these patients for whom there is more evidence and patients for whom there is less evidence and other subgroups?
Thank you, Alex. And I wondered if you could briefly summarize how you looked into these difference between the higher risk and the lower risk patients that you're reporting in this study.
So we leveraged our BESTMED consortium. It's 10 health systems across the US and the 2 nationwide health insurance plans that all contributed data over a 9-year period, so electronic medical records data and claims data. And that allowed us to look at initiation of new diabetes medications of patients with, across various characteristics and subgroups.
Yeah, Alex, this is all very important information. So what did you find?
So what we found was that, as expected, for patients for whom there was good, rigorous evidence available, patients at high cardiovascular risk, there was a huge increase in prescription of new diabetes medications that are proven to reduce that cardiovascular risk. But we saw practically the same findings for patients who had lower cardiovascular risk, for whom that evidence really wasn't quite there. So we are essentially finding that patients seem to be making these projections, extrapolations of the evidence that exists for one group of patients onto a much broader population.
That's interesting. I at first I was thinking that people were actually adhering to the guidelines in making the selections, but from what you just said, they may be adhering to the commercials they see on television as much as the guidelines. Can we conclude that, or what do your findings suggest we should do from here?
That's a great question. I think, and I don't know that I would necessarily sort of say that people are following commercials. I think people may be thinking in patients' best interests that if these medications help high risk patients, that they help lower risk patients as well. And but I think what our role here in academia is to not leave gaps for people to fill in with their own assumptions, but not to leave areas uncovered by research, but to conduct more investigations to provide that missing evidence so that clinicians, so that patients can use that evidence for at least all the large groups of patients to make informed decisions on what the best treatment is.
I'm just really enthusiastic about this set of observations where we're very excited to see that high risk patients are getting evidence driven care. And so I guess I am also enthusiastic about a number of the other articles in this very issue where the next question might be addressed, which is, do these medications that are useful in high risk patients actually benefit lower risk patients? So can the BESTMED Consortium help us with that?
So that has indeed been our goal, and we're working and publishing studies in that regard, and many of our colleagues are. And I think now the evidence is gathering that, in fact, yes, these patients do benefit, and the absolute benefit may be lower because their absolute risk is lower. But generally, if millions and millions of patients on the population scale, yes, I think you'll see these benefits. So I think ultimately the clinicians and patients in this case were making the right decision.
It also, in terms of risk stratification, there's also the question as to whether all patients are being adequately stratified in terms of their risk. So there may be some that people sort of assume are lower risk that may have some underlying factors that make them higher risk that haven't been determined. What sort of future studies are you thinking about, if you can mention some of the things you're thinking about?
That's a great question. So we're investigating, for example, whether all patients with kidney. So it's known that many of these new medications, SGLT2 inhibitors and GLP-1 receptor agonists, help with kidney disease in addition to cardiovascular disease. But we're investigating whether all patients with kidney disease are created equal, so to speak. For example, there are patients who have albuminuria, there are patients who don't, and there are for other medication classes like we already love and use, like ACE inhibitors or angiotensin receptor blockers, there are differences. They help patients much more. They help patients who have albuminuria. They don't provide extra help to patients who don't. So we're investigating whether something like this might be the case for the diabetes medications as well. And there are also, many other now indications for these new medications. Cardiovascular ones were the first ones we learned about, but now there is liver disease, there is maybe lung disease. People are even talking about cognitive functions, and many other fields. So there are many other ways to look at this.
So the message is stay tuned. Alex, thank you
Yes.
very much for joining us. Fascinating information, and we look forward to more things coming from your group in the months and years to come. As I mentioned at the outset, this next edition of the journal has two special items containing important information and recommendations that deserve particular attention. We're going to highlight them next, but details can be found in the journal, and I'd certainly encourage all of you to have a look at the written articles. Jane, why don't you start with the first one?
It's a very exciting move that the ADA has made into formalizing the way we are addressing diabetes. And along with that, we have been working through developing a standards of care in overweight and obesity. This first section that is highlighted in this month's journal is about screening, diagnosis, and evaluation and staging of obesity in adults. This is such an important article. First and foremost, because obesity is increasingly common in the US and globally. And we need to be able to think about it as clinicians in terms of the potential consequences for the patient that we have in the room with us. So what the ADA has developed and shared in this article is a comprehensive evidence-based guideline on screening, diagnosis, and evaluation. Yes, that is the title, but the specifics are very important. First, it is really critical that when you see a patient in your clinic, you are monitoring their weight trajectory. That way, you may be able to anticipate before the obesity has gotten to a stage 3 level of obesity. You may be able to anticipate and work with the patient to determine strategies to decrease this morbid problem in them. And then you want to go after some early interventions. We, of course, are going to focus originally on diet and physical activity and decreasing sedentary behavior, but then also empowering patients to come up with their own solutions and also to use medications that are available specifically related to that individual's potential complications. We should be looking at this in people who, just as we would for somebody with hypertension, if I identify obesity or overweight that is progressing in an individual, I should be monitoring that twice a year. This is not something that is embedded in our typical practice patterns. And then sort of to treat this as a very important and critical factor in our practice and in our relationship with that patient. So when you find somebody suffering with obesity or overweight, then you also want to do a comprehensive assessment of their general health and figure out where it is that you and that patient can work together to improve their long-term health. So I think that all of us will benefit from reading this article and taking the learnings from this article into our day-to-day practice, which is what we want this journal to help you with, your day-to-day practice. Thank you.
Yeah, it's really part of changing everyone's mindset about obesity, and I think I agree with you, Jane. It's very, very important to consider what's written in this article and these standards. Let's move on to the second special item entitled "Employment and Diabetes: A Statement of the American Diabetes Association." And the ADA points out that most people with diabetes are part of the US workforce. And to that end, the diagnosis of diabetes, and in particular the use of insulin, shouldn't be used to determine an individual's fitness or ability to perform a job. Diabetes usually doesn't limit a person's ability to do their job. And if an employer raises safety concerns due to a work setting or something about a worker's ability to perform essential job functions, the worker should be individually assessed to determine if they can fulfill essential job duties and what accommodations, if any, are reasonable. It's not just a knee-jerk response. You see diabetes, you see insulin, and you take action. You've got to assess the individual. And that's so important. And that's what this statement really reviews, how to do that. It reviews many of the issues inherent to diabetes, its treatments, and potential employment issues and concerns. It also contains a great deal of very important information and guidance. It has an overview of legal considerations for workers with diabetes in the United States and the legally required interactive process between the employer and the worker. It talks about how to evaluate individuals with diabetes with respect to employment, and it also provides practical considerations for a worker, their employer, and their healthcare team about how to accommodate for diabetes. I personally think this statement provides very, very important guidance for anyone with diabetes, for those providing care for them, and who may be employing them. Just as a personal note, with my own career at Joslin Diabetes Center, my original mentor years ago was a guy named Leo Kroll. Leo was a wonderful man, and he really had a focus on employment and diabetes issues back decades ago and was advocating for appropriate approaches. So I'm really pleased and in honor and in memory of Leo's work and all the other people with diabetes in the workforce. These statements are extremely important to read through.
Yeah, I think that this is really exciting and important to put into an article so that people living with diabetes can use it to help them when employment issues arise, and also so that employers and HR can understand that it's not a special right to need to check your blood sugar. It's very important that you would like to have employees and their employers understand how important it is to take great care of diabetes for their long-term health and well-being.
Amen. Thank you, Jane. Let's move on to the articles that we're going to discuss. Jane, why don't you start off with one that you picked out?
Right. I am first and foremost interested in behavior, and I am really excited about this article that we're publishing called Behavioral Modifications from CutDM, including lifestyle modification and self-efficacy. The lead author, Giovanna Vidovic, on behalf of all of her authors, had the objective to investigate diabetes self-management in the setting of diabetes, self-care, and education management, plus a CGM. And it was an open label randomized study, and they studied 119 Latino participants with poorly controlled diabetes. And they were looking at people and their response to either the educational intervention or the education plus CGM. And what they found was that in both groups, they had a lovely improvement of days of any physical activity and about a 20% with more than 10 minutes of brisk walking. They improved their nutritional scores. They improved their foot care, but interestingly, they didn't improve their medication use. So I'm not sure where all of that plays together. But what this does for us as clinicians taking care of people living with diabetes is it empowers us to reach out and use education as much as possible to really support the optimal care of our individuals with diabetes and to know that CGM is an additive benefit there.
Thank you, Jane. The article I'm going to talk about is Pharmacist-Driven Pre-Visit Planning to Optimize Prescribing in Type 2 Diabetes by Chan et al. The authors point out that adolescents and young adults with type 2 diabetes face clinical and socioeconomic barriers to initiation of guideline-directed therapy and suggest that ambulatory care pharmacists, as part of an interdisciplinary care model, can address medication access and prescribing gaps. And I've always found pharmacists can be extremely useful in the clinical setting in this way myself. And the authors demonstrated this by studying the implementation and outcomes of a pharmacist-led pre-visit planning quality improvement initiative that was designed to optimize prescribing of guideline-directed therapies in this population. The pharmacist-driven quality improvement initiative was conducted at University of Chicago Kovler Diabetes Center, and they conducted pre-visit chart reviews assessing eligibility for SGLT2 inhibitors and GLP-1 receptor agonists and dual agonists, evaluating insurance, communicating recommendations to providers, and going over the whole potential. Further details can be seen in the article. The results show that 93 unique patients had these pharmacist notes prepared. The providers actually provide recommendations that were made for 38% of the patients, while 34% of the recommendations were not implemented due to missed or canceled visits. Among patients with the follow-up data, the mean A1C decreased from 8.7% at baseline to 7.8% at 3 to 6 months, and the prescribing rates improved. So the authors conclude that the pharmacist-led pre-visit planning can improve access to guideline-directed therapy and support glycemic improvement in adolescents and young adults with type 2 diabetes. And this interdisciplinary care model addresses medication access barriers and therapeutic inertia in high-risk populations. My perspective on this is definitely a step in the right direction. But what struck me is, yeah, 1/3 missed or canceled the appointment. And this is in a population of adolescents, which, they're a tough group. So I can appreciate the challenges. But I think this is really at least giving us some sense as to how we can be more effective. And hopefully these sorts of studies can continue. Jane?
Thanks, Rich. And I just want to reinforce what you said, that even though a third of people didn't go, still the ones that did go had a benefit. And in this population, you probably have to keep trying all sorts of different strategies until you figure out the one that works for that one individual. So in a theme of trying to improve diabetes outcomes in a primary care setting, the next article is entitled RAS Inhibitors for Primary Prevention of CKD in Type 1 and Type 2 Diabetes, a Systematic Review and Meta-Analysis by Benrou et al. And in this study, they wanted to understand the benefits of RAS inhibitors in people without CKD. Here again, like some of the other articles we're discussing in more details, we're looking at the general, relatively less high-risk patients. And so what they used was a very elegant meta-analysis strategy where they were able to find 15 RCTs that identified people with diabetes but no established CKD. 9 of these studies were in people with diabetes, and 6 were in people with type 1 diabetes. Notably, for the people with type 2 diabetes, they typically had comorbid hypertension, When you are using RAS inhibitors in patients without CKD and comorbid hypertension in the population with type 2, they saw a relative risk decrease to 0.83, or about a 13% improvement. Of note, in the people with type 1 diabetes, notably normotensive, this same outcome was not observed. There was no benefit noted. So the conclusion is, and I think rightly so, that it is very reasonable in your hypertensive patients with type 2 diabetes to consider RAS inhibitors, even if they do not have proteinuria, because it will have the effect to decrease proteinuria. And there is more to know about primary prevention of albuminuria in other studies available in this very same issue.
Thank you, Jane. I think this is, helping to get us more detail into how we should be prescribing many of these medications. My next article, Goals of Care Among Caregivers of Youth with Type 1 Diabetes. I guess I'm getting the youth and pre-adolescent ones today. Considering I have 3 grandchildren in that age group, I guess I can handle it. Uh, the authors here sought to characterize the goals of care among caregivers, and as the people that are providing support and care of youth with type 1 diabetes, and also evaluate psychosocial factors associated with caregiver priorities using what they describe as a structured narrative-based goals of care framework adapted from the 3-act model. A 3-act model is a narrative framework that structures stories into 3 distinct parts: setup, confrontation, and resolution. The details of the research design and methods can be found in the article, of course, but in summary, the authors conducted semi-structured interviews with 30 caregivers of diverse youth 8 years of age and older that have type 1 diabetes. The caregivers and youth completed validated measures of diabetes distress, quality of life, psychosocial symptoms, caregiver burden, and resilience in family conflict. So the results showed there were 3 major themes that have emerged: health management, emotional and social well-being, and personal development. Interestingly, the caregivers consistently prioritized emotional health, normalization, and fostering independence, often emphasizing these above meeting glycemic targets. Diabetes distress was significantly higher among caregivers than in the youth age 8 to 12. Yeah, the people helping them are more concerned than the kids themselves, which highlights, of course, the middle childhood as a period of heightened psychosocial strain for caregivers and youth, as we all know. The authors concluded that caregivers of youth with type 1 diabetes identify goals beyond glycemic metrics to emphasize emotional well-being, autonomy, and quality of life. Integrating structured goals of care discussions into routine diabetes care may improve alignment between families and clinical teams, supporting what the authors describe as a person-centered, developmentally informed diabetes management. And I think this article highlights a very challenging age group with some hints as to how to approach it. Jane, what do you think?
Yeah, absolutely. As I sort of mentioned earlier, I think that we need to be continuously creative. And once we find something that works, we don't need to expect it to work in everybody, but we may find a large portion of individuals whom we really can get some traction with. And the improvement of glycemic control at this sort of early time in their long life with type 1 diabetes is so urgent that we just love to publish these kinds of articles that we know you will enjoy reading.
And that, as we come to the conclusion, Jane, that there were a lot of really other good articles in this edition that feed on some of these themes. That does bring us to the conclusion of this edition of Points of Care, the podcast for the journal Diabetes, Obesity, and Cardiometabolic Care. As I mentioned, we've certainly highlighted some key articles with the 2 interviews and the 4 others. We've discussed the obesity standards of care and the statement of employment in diabetes. And all of this is in the next edition of the journal, which I strongly urge you all to open up and take a look at. And the full contents of Diabetes, Obesity, and Cardiometabolic Care can be found online at Diabetes Journals, one word, .org, diabetesjournals.org/DOCM-CARE, C-A-R-E, with a link in the episode notes. Watch for our next journal issue and the next episode of this podcast, both of which will drop in mid-October 2026. And please do subscribe to the Points of Care on your favorite podcast app so you won't miss what's next in diabetes, obesity, and cardiometabolic care. Points of Care is made possible by our dedicated donors, listeners, and partners. Thanks to your support, we're changing the future of diabetes. I'm Dr. Richard Beaser. On behalf of my co-host, Dr. Jane Reusch, thank you very much for joining us.